someone? Have you ever cared?
Hello again.
Do you miss someone?
I'm Dr. Hung Vu, and our show is America's Healthcare Crisis. The topic of discussion for our program tonight is medical ethics. The field of medical ethics covers a number of subjects that are of vital importance to the practice of medicine. Of course, the first principles of medical ethics were outlined from the very beginning in the Hippocratic Oath. Obviously, the practice of medicine has evolved and has become much more complex nowadays, so that hundreds of articles and numerous textbooks are being published every year on the subject. Within the scope of our production here at Access Los Altos, I'd like to divide our discussion on this very broad and important subject into two segments. During the first part of our discussion, we'll give a general introduction to the field, and in the second part, we will approach the subject and talk about the larger part of the applications of different principles into the current health reform in our country. And to help me with the discussion of this important subject, I'm very pleased to have with me two prominent guest speakers who can speak about medical ethics with authority and credibility. Let me introduce them. My first guest is Dr. Ernle Young. Dr. Young is a Ph.D. He is the co-director of the Center for Biomedical Ethics at Stanford University. Welcome to our show, Dr. Young.
Thank you.
It's nice for you to be here tonight. And my second guest is Dr. Richard Wheat. Dr. Wheat is a MD and internist, and is currently the medical director of Alchemy Hospital. Dr. Wheat, welcome to our show.
Thank you.
Gentlemen, medical ethics obviously is different now from the time Hippocrates, I still have difficulty with that word, defined it in the beginning of medicine. How do you define medical ethics in the current atmosphere of medical practice, Dr. Young?
To define medical ethics, one needs to go back and define morality, and then to define ethics, and then to define biomedical ethics. So I'll just take a minute to do that. Morality may be defined as those attitudes and behaviors, either of an individual or of a group, which for the individual or the group express the vision of the highest good. The highest good is often culturally determined, so that in a Christian culture, the highest good may be tied to Jesus. In a Jewish culture, it may be tied to the Torah. In a Buddhist culture, to the Buddha and teachings of the Buddha, and so on. And the attempt of morality is to express in daily attitudes and actions that vision of the highest good, whatever it is. Now, if you allow at the outset that the vision of the highest good may vary from culture to culture, then you begin to realize that morality is often conditional upon that cultural vision. And furthermore, even within a single tradition, morality may change from one generation to another, so that even within a predominantly Judeo-Christian culture, there may be generational differences in the way that people perceive their moral obligations. Now, ethics, I think, is that discipline which tries to look at moral arguments, pro and con, and to ask whether these are consistent and whether they cohere with the vision of the highest good. Mm-hmm. So it's a more objective analysis of what is going on, and occasionally it moves from analysis to prescription, to suggest what ought to be going on in light of this vision of the highest good.
Right.
So, for example, with respect to slavery in this country, people who were ethically minded would question the morality of what was happening and would suggest what ought to be happening in order to bring the practices into conformity with the vision of the highest good. And that's perhaps how slavery was abolished and how the civil rights movement advanced. So bioethics may be defined as the attempt of people who step back and engage in ethical reflection to examine the moral arguments that are being proposed, pro and con, with respect to the many issues that arise in the modern practice of medicine. And these issues multiply rapidly because of technology, because of economics, because of the law, because of new diseases, because of demographics and others. So we have constantly proliferating issues, and therefore plenty of opportunity to try and figure out what is going on and what ought to be going on.
It's really fascinating, you know. Is medical ethics a integral requirement of the curriculum at Stanford, or it's still an elective?
Both. More and more it's a requirement, and there are elective opportunities.
Okay.
We are now attempting really seriously to integrate ethics from the first year right through the clinical years into the requirements of a medical education.
Okay.
Of course, we've had to compete with other hardcore subjects.
Right.
But in addition to those requirements, in the first year, in the second year, and then in the third year, there are elective opportunities as well.
See. How about other medical centers around the country?
I think that's true generally of all medical schools throughout the country, that there are required elements and there are elective opportunities, and all of us who are engaged in it wish there was you know, more time for the required courses, but we have to compete with so much in the hard sciences that it's very difficult. And until the national boards require questions in bioethics, this is not going to be as central as we might like.
Who are considered the experts or the authority in issues of medical ethics? Say, for example, as a practicing physician, I'm lucky to know you and Dr. Wheat through a personal connection, but who can the average practicing physician call and ask for guidance in regard to how he applies these principles in his practice?
Well, the field of biomedical ethics is probably 20 to 25 years old. And I've been at Stanford for 21 years, so I've sort of grown with the field. And I would think that in every major medical center, and now virtually in every community hospital, and Dr. Wheat can talk about that, there are people with either practical experience or academic training in bioethics who are available not only for physicians, but available for patients and families and nurses and anybody else who may have genuine ethical concerns.
Is biomedical ethics being taught in law schools?
Not biomedical ethics, perhaps, as much as the ethics of legal practice. And that is becoming, in the same way, either a requirement or an elective, and in some cases both. And similarly, journalists are becoming interested in the ethics of journalistic practice. Business schools have courses in business ethics.
I have always felt that way, that the ethical part of any profession is really fundamental in any kind of teaching or education. Dr. Wheat, let's talk about El Camino Hospital. How is the Committee of Medical Ethics being formed, and how is it operating?
Well, we began an ethical program, if you will, at El Camino almost 20 years ago, fairly early in the time of ethics as it's involved in medicine. And that's consisted of a medical staff committee of people who were interested in being involved in ethical questions, ethical decisions, working with families or nurses or fellow physicians on problems, dilemmas in the medical care of individual patients. Those could be many and varied. End-of-life decisions, whether a child should go home towards the end of the life or remain in a hospital till they die. Questions where nurses and physicians have differed in their feelings, and there's a tremendous gender difference in what male physicians and women nurses often feel about patient care. And resolving those issues becomes an ethical question, so that some of the ethical issues which we address relate to communication problems, some to true ethical dilemmas in patient care, end-of-life decisions, and so forth. We also are active in the educational process, not only educating ourselves in the ethics area, that is to say, the ethics committee, but in educating our fellow physicians and nurses and other members of the care team. Medicine these days is presented as a team effort. We have co-professionals, physicians and nurses, as well as a number of other people who play a very close part in the care of individuals. And these questions come up for all of them. With the advent of AIDS 10 years ago, there were very great ethical questions that arose around that issue. Many of these questions can't be finally answered in any given way, but they need to be talked through to help people understand problems. The purpose of ethics is to allow people to have some autonomy, or at least one of the purposes in their lives. Physicians no longer are the paternalistic people who tell people what's going to happen, or play God, as you suggested, and make the decisions themselves. Part of the trend and the force of ethics is to allow people to make their own decisions, informed decisions made on a basis of getting all the information from physicians and others that they can get. So that's the way we approach it at El Camino. We were very fortunate for a while to have one individual who became our clinical ethicist and was in that position for several years. We unfortunately lost that individual, and we are in the process of recreating that team which we had earlier. Ethics is also changing as medicine is changing. We have been a hospital-based ethics committee. We're now becoming part of a continuum of care from inpatient to outpatient, and as fewer people are in the hospital, more and more people are cared for throughout their illness or into time of death in their home. And that means we need to begin applying the principles of ethics and work through these issues on an outpatient basis as well. And we're currently restructuring our program to make it a continuum of care. All of you are aware that we have hospice care and so forth, and there are many ethical issues there, but those are sort of determined by the fact that somebody has entered into a hospice program. But the medical issues of how far we go with care, what type of care, what about the cost of different types of care, are ethical issues, a majority of which take place now in an outpatient setting rather than an inpatient setting.
The question I have in mind is often it's very difficult to know exactly what is best for our patient. I guess to the extreme, the surgeon who does beautification procedures may think that it's of great benefit to the patient, and that can be very arguable. You know, breast augmentation, you name it, he changed the whole body to make the patient feel better, and he feels a great justification for it. How do you feel about that? I mean, sometimes we don't know what's best for the patient. Is that best for the patient, or maybe best for ourselves, our own?
Well, I think that one question is it our decision to decide what's best for that patient? I don't think it is. I think the individual has to make that decision. We can give them all the information that we can about it, both the fact that maybe your nose doesn't need to be straightened, but you need to develop more confidence in yourself to have a greater self-image. But at the same time, sometimes those plastic surgery procedures are of enormous benefit to individuals. So again, these issues become blurred, and it's difficult to say what is best for the patient. And I'm not sure doctors are necessarily the ones who either have the right or the power or the place to tell patients what's best. I think that's the old paternalistic approach, which I'm happy to feel we're beginning to get away from.
On the other hand, some of these procedures you mentioned may be very costly, and do we want to get into the position where people can have whatever they desire in terms of medical treatments, however costly they may be, when we have 39 million who are denied access to the system, direct access to the system? I mean, your question is a very important one because on the one hand, there are enormous societal pressures on people to have a certain kind of appearance, to be thinner or, have smaller figures or larger figures or straighter noses or whatever it is. And one could argue that in a society that values these extrinsic qualities, somebody is going to be disadvantaged by not having them, and therefore psychologically in need of these services. I mean, you could make that argument. Or you could say, hey, the society's expectations are wrong. Instead of focusing on the external, we need to look at who a person essentially is, and get our priorities straight in terms of what's really important in medical care. Very interesting question.
Yeah, that's exactly the point I'm trying to make, because as a family physician, very often my role is not so much to treat, but to share information, to coach, to teach, and to be a role model. Really strengthening a self-confidence is a very important part of medical treatment, in my opinion. The easier part would be like, saying that if I augment your ear or, heighten your nose, you look better and you feel better. But there's a blurry point there, because people make a lot of money doing that too. So
I think all of us would agree with you, certainly what Dr. Young is saying, what you're saying, and you know how I feel about it, that that's not necessarily for society's better interest. The problem is that we as a culture and society have said that people can have whatever they wish if they can pay for it. And we're clinging very strongly to that philosophy. We can turn around and say it's not to the better good of society that we leave 39 million people without adequate medical care, or 1 in 4 pregnant women has no prenatal care in this country, which are abominable statistics. But the majority of our present population think otherwise. They feel that although that's very bad, when it gets right down to it, I need what I want, and I'm going to get it.
But isn't that a role of the ethicist, anyway, is to raise the consciousness? So people at least think about it. Instead of just automatically define what they need is what they want.
Well, that's one of the important things that ethicists can do. I mean, for example, we've mentioned autonomy, and as Dr. Wheat says, autonomy has come to be thought of as an entitlement to have whatever one wants. The original meaning of autonomy in the writings of John Stuart Mill and Immanuel Kant were the freedom to make personal choices without undue interference, so long as one's choices did not harm or endanger others. So that was a negative right to freedom of choice, and it's become thought of as a positive entitlement. And this is a major issue that we'll get into later when we talk about resource allocation. Inflated expectations. Undue expectations, undue demands, the thought that wants become entitlements, and a loss of vision in terms of what the greater good is. It's a me-centered society in many ways. You
started from the very beginning talking about morality. To me, that's where it comes around too, because to me the best of each one an individual is really the highest moral goal that we have for our nation or as a culture. And I'm concerned that some of that is not only so blurry but outright almost violated. I mean, some of the values that we have in our societies are very disturbing.
Unfortunately, some of these issues are being cast in concrete by court decisions, which are making it impossible to deny for whatever reason. people the right to do what they wish. And that's becoming a major issue in healthcare finance, for example. You cannot turn down someone who wishes something, no matter how futile that may be.
So the question would be, how do we communicate as physicians to the lawmakers, to the lawyers, so that we can influence their thinking?
I think that's happening at many levels. I mean, for example, the California Medical Association has a very active lobby in Sacramento. I sit on the California Medical Association's ethics committee, and they are exercised by some of the issues we've talked about, as well as a whole range of others, and represent the views of organized medicine to lawmakers consistently. Now, that's a double-edged sword. I mean, on the one hand, it has positive benefits. On the other, one sometimes feels that it's self-serving.
Yeah.
And anticipating our next segment of healthcare reform, you know, I feel kind of sad about the way American medicine, as organized, has in many ways helped to subvert the whole reform initiative. But on the one hand, it is a positive, and that's how, I mean, as an example of how the CMA has had a positive effect on the law in Sacramento, as we all know, until recently, paramedics have had very little discretion in the field when called, when it comes to resuscitation attempts. And now, thanks to the CMA lobbying effort, it is possible for people to buy a prescription bracelet or necklace which says, I do not want a resuscitation attempt. And if a paramedic is called and sees that necklace or bracelet, that person does not have to behave like a trained animal, but can exercise some judgment and say, okay, I'm going to leave that. Now, I think that's an important advance.
Right. See, in my opinion, okay, again, this is a personal opinion, I can see that the healthcare crisis will be helped or improved by the contribution of a number of different people, lawyers, physicians, paramedics, whoever you're talking about, the consumers, the awareness of consumers. But I would like to see that the ethicist is truly the conductor of all those efforts.
Oh, that's wishful thinking.
I
would love it.
I would love that, too.
I would love that.
Because to me, that is where the bottom line of the crisis is, my understanding. So,
well, you know, that in the best of all possible worlds, that would be true in the medical school, that would be true in the legislature, it would be true at the, you know, but it's not going to be like that, because politics is all about power, and people in ethics have very little power. We may have influence, but we have no power.
I don't know that. Well, I would argue with that. You know, kings and presidents only last a few years or a dozen years, but the morality is taught to us by Christ or Buddha in the last thousands of years. I would argue, I would take issue with that, saying that they don't have power. I mean,
oh, they have power. No, that was not my point. The point is that people may pay lip service, or they may profess to value what the Buddha says, or the Quran, or the Torah, or Jesus. But at the operative level, in terms of daily life, the real values may be quite different. And I'm not gainsaying the power of the great ideal figures of history, because they do endure. But at the operative level in daily life, people are motivated and driven by forces that may be very different from those they profess. So I'm fascinated in terms of doing ethics about the difference between professed values and operative values, not only in individuals, but in institutions and countries. I mean, you look at our country, we have this wonderful profession. Give us you're tired, you're poor, you're homeless, you're hungry.
Well, the saying is that you don't listen to what they say, but watch their feet, you know.
Exactly.
Anyway, we're already running out of time for the first segment. This is really so enlightening, and I enjoy this so much. We have just approached the sort of introductory initiation to the field of medical ethics as being perceived in our times. I'm Dr. Hung Vu. Our shows is called America's Healthcare Crisis, and the topic of discussion for our program tonight is medical ethics. I'd like to invite you to watch the second part, in which we will try to find out what is the larger picture, whether we can apply some of the concepts we're talking about in theory into helping with the reform of the American healthcare crisis. So long. Thank you for watching. I'm Dr. Hung Vu. Good night.
Someone, have you ever cared? Do you miss someone? Have you ever shared? Do you need someone to always be there when you feel lonesome and deep in despair? Do you need someone to dry up your tears? Do you need someone to always be near? Do you have someone to stay through the years?